All right, we're going to go ahead and resume our conference here. The next speaker is someone who I've known quite well, in fact, since her days as a neurology resident here at UPMC. And so she completed her neurology fellowship in neuro-oncology here as well. And she works with me here at Magee. She's a crucial member of the team that deals with breast cancer and gynecologic cancer with neurologic manifestations. I will introduce you to Dr. Megan Mantica.
Okay. Well, thank you so much. This topic is really very interesting to me. When I first started over here, I had a very young woman who came in with very mild symptoms that were very similar to many pregnant women's symptoms, headaches, maybe a little bit of nausea. And she ultimately was diagnosed with a glioblastoma during her pregnancy. Oh, is that better? Okay. And the management for her was very challenging. And it really made me go back and look and see, well, what do we know about this population? What do we know? How can we treat them well? And then since then, I've just really have seen so many different young women come through my clinic in neuro-oncology and really expressing interest in pregnancy. And these are patients who are diagnosed with primary brain tumors. So I've since then really developed an interest in this, and I think the field of reproductive neuro-oncology is in its infancy right now, but as our treatments are getting better and the prognosis of our patients with lower grade tumors is improving, I think that this field is really going to be emerging in something that we're going to have better guidelines and better treatment for these patients. So I'm very excited to talk about this today. And as you'll see, I wish we had more definitive data to show you, but I'll give you what we have right now. So the field of neuro-oncology actually really starts with the field, the field of neuro-oncology really starts with the field of neurosurgery and actually dates back down to 10,000 BC with the Inca period. And they'd perform something called trepanation, where you're actually cracking open the skull. And they did that for headaches and bad spirits and traumatic brain injury. So the thought was, let's leak out all those bad things from the brain. And, there are some reports that in some tribal communities that trepanation is actually still being performed today. The kind of first real modern neurosurgical procedure is thought to have been in 1879. And based on the description, I had to look at kind of this old report. I think it was probably a meningioma. I'm not really sure. I'm not sure that they knew what it was either. And then the first guide about how to treat brain tumors really came in 1888. And then in kind of the early 19th century, there was a flood of documentation and reports about brain tumors, how to treat brain tumors, these marvelous anesthetic mechanisms and different new techniques for treating. So the field of neurosurgery has really expanded, but this has also expanded the field of neuro-oncology. And then in 1895, we had x-rays, and so they started to localize these brain tumors rather than just cracking open the skull in many different places. And the very first report that I could find of pregnancy and brain tumors was in 1898, and this was by a French surgeon, Bernard. And I don't read French very well, but as best as I can interpret it, I don't think she did very well. But this is the very first, so kind of exciting in this field, very first pregnant woman with a brain tumor that they performed a surgery. Then in the 1950s, jumping ahead, how we treated these tumors drastically changed, and our understanding of these tumors changed. So they actually started performing total hemispherectomies for our glioma patients, and so they would actually remove off half of the brain, so the whole right lobe of the brain or the whole left lobe. Not surprisingly, they didn't do very well, but survival was modest. And then if we jump ahead even further, right? So now about 20 years ago, we have had a real significant boom in the treatment of our brain tumors. And so performing maximal safe resections, performed radiosurgery, we have fractionated radiation to the field of where the tumor is, and then significant advances in chemotherapy, targeted therapy, precision medicine, and the advent of molecular age of tumors, and also immunotherapy. And then jump ahead another 20 years, and here we are today, and we're actually giving a talk about pregnancy and brain tumors. Not that it's possible, but how do we do this safely? So I think that this is really progressive, very interesting. And again, I think that this is just a very emerging field, really in its infancy right now. So again, I'm really excited to be here and talk about this. So brain tumors, this is pretty important topic. So in the United States, about 79,000 cases of primary brain tumors are diagnosed each year. 30% of them are going to be malignant, and it's the second most common cancer in children less than 14. It's the third most common in ages 15 to 19. 700,000 people in the US are living with a primary brain tumor. 58% of people with brain tumor are women, and 17,000 people die a year. And there's over 120 different types of brain tumors that exist. Your risk of having a brain tumor is less than 1%. So what about our young women? This is kind of a rough approximation of our reproductive age women. There's 31,000 people in the United States right now who are living with a brain tumor. And in this particular age group and in this particular gender, it's the fourth leading cause of cancer-related death. So very impactful. What about in pregnancy? So in primary brain tumors during pregnancy, this is really uncommon. The incidence is actually pretty similar to non-pregnant women, and we see 2.6 per 100,000. And the symptoms tend to be similar between pregnant and non-pregnant women. Most often we see meningiomas and gliomas. The gliomas tend to be the more symptomatic, so we often will find that in the second and third trimesters. And then we see acoustic neuromas, pituitary adenomas, and other types of brain tumors as well. The diagnosis and treatment is really a multidisciplinary care, as is neuro-oncology in general. It's not just one. We really rely on our neurosurgeons, our neuro-oncologists, our anesthesiologists, and our OB-GYNs, our MFM, and neuroradiology. Everybody is really crucial when it comes to women and pregnancy and brain tumors, and we really need their expert opinion for this very small subset of patients. And again, I'm just highlighting the point that this is something that is fairly morbid. It's, again, the fourth leading cause of cancer-related death in this reproductive age group. So what is a brain tumor? Brain tumors are abnormal growth of tissue in the brain, spinal cord, and sometimes in the spinal fluid, and it disrupts proper function of the brain. We refer to these based on where they originate. So do they come from astrocytes, oligodendrocytes, ependymocytes, and are they malignant or benign? We often think about them as either primary or secondary, and secondary means metastatic. Our primary brain tumors are what I'm going to focus on here, and these are the ones that originate in the brain and the spinal cord. So when we think about brain tumors, we think about them differently than other types of cancer, in that they typically, once they start in the brain, they tend to stay in the brain, and they typically don't spread outside of the brain. It's important also to distinguish that from the metastatic or secondary tumors, and these are tumors that originate from another part of the body and then go to the brain. So that would be something like breast cancer or lung cancer that starts somewhere else and then metastasizes to the brain. The common signs and symptoms of a brain tumor. So it's really depend on location. So I wish I had the Netter's diagram up here, but it's anatomical location. We can really figure out exactly where it is, and oftentimes focal neurologic deficits will give us a clue. It depends on the size, and of course the type of tumor plays a significant role in what they might present with. We often can see increased intracranial pressure, so that would be headaches, papilledema, nausea, vomiting. Focal neurologic deficits, again, we can see non-traumatic intracranial hemorrhage, hormonal changes, especially if we're thinking about pituitary tumors, visual changes, if it's, again, pituitary tumors or if it's in the frontal or occipital lobes. This is somewhat of a silly diagram, and I found it by looking for common signs and symptoms of pregnancy, and then also common signs and symptoms of brain tumors. And interestingly, these are all in both. And so I was talking to some people before I came up here. I'm about 7 months pregnant right now. And when I look at this diagram, I was thinking, I have almost all of these that, maybe with the exception of seizure, but, the nausea and vomiting in my first trimester, issues with vision, dry eyes, headache, balance issues. I waddle now instead of walk normally, and I had lightheadedness. So all of these things are really common in pregnancy, but these are really important and common things that we see in primary brain tumor. So specifically looking at headache, this is something that we can see in upwards of 90% of patients who come in with brain tumors. And when we think about headache, Dr. Kanicki gave a great lecture about headaches and pregnancy. And the difference in brain tumors is that these are unrelenting, progressive headaches, that they do not get better. They're often associated with nausea and vomiting. And then we often see worsening with transient increase in intracranial pressure. So like Valsalva maneuver, coughing, exercise, sneezing, bending over, that we can see this exacerbation of headaches. So thinking about some of these red flags, I would say this is different than a normal headache. For nausea and vomiting, again, this is seen in 25% of people who present with a brain tumor. And when we think about it in pregnancy, yes, a lot of people have nausea and vomiting. That's usually in the first trimester. Any patient who has new onset nausea and vomiting in the second or third trimester, we really should do further workup and try to evaluate these patients, that would be abnormal. And then looking at some of these other, of course, focal neurologic deficits, which I don't have on here, we always want to do further workup for that. There's never a good reason to have a focal neurologic deficit. Though common things being common, if anybody presents with a neurologic complication in pregnancy, we always want to make sure it's not eclampsia. That's far more common than a brain tumor. But again, we always need to do the workup and make sure, because this is something that's highly morbid and has significant mortality. The most common primary brain tumors that we see are meningiomas and gliomas. Meningiomas are the most common primary brain tumor in adults, and this is also true in pregnant women as well. And then gliomas are the most common primary malignant brain tumor. So that, I'm always asked about that. Meningioma is the most common, and then gliomas are the most common malignant one that we'll see. And then I listed some of these others here, but these are fairly rare. And Dr. Spiro gave a nice pictorial of pituitary tumors and kind of the physiologic changes we see with pituitary. So pituitary adenomas are something that we see commonly in pregnancy as well. When we think again about primary brain tumors, we don't use the staging system that we use for other types of cancer. We actually use the World Health Organization grading system. And again, this is because tumors don't behave like other types of cancer. They stay right within the brain. And they use the classification based on histologic criteria that look at nuclear atypia, pleomorphism, necrosis, and we grade them from 1 to 4, with 1 being your typical more benign pediatric tumors, and as we go higher up in grade, they become more aggressive, with our grade 4 tumors being our most aggressive tumors, are typically our glioblastomas. And it's really important to distinguish between those lower grades 1 and 2 and grades 3 and 4, that as a clinician, we often will help determine treatment based on those grades, and that oftentimes we are far more aggressive with our higher grade tumors, as we should be. So these are meningiomas. So this is a scan showing kind of a fairly large meningioma. And this, again, is the most common primary brain tumor in adults. And again, we see this commonly in pregnant women as well. That this accounts for about 30% of all primary brain tumors. It arises from the meninges, or the lining of the brain in the spinal cord. And the symptoms that we see are often related to compression. So while it's on the surface of the brain or the lining of the brain, it can push down on the adjacent structures, and so it can have vascular issues or affect certain areas of the brain that are near that it's pushing in on. There's some observational studies that have shown a significant growth of meningiomas with pregnancy. The incidence is fairly rare. So however, one thing to keep in mind is that even though some of these observational studies, and I'll have a couple slides about this, do show that there can be an increase in size, we don't have any evidence to support that pregnancy is associated with the development of meningiomas, that they don't develop during pregnancy. The incidence is fairly rare. So I talk about these being the most common brain tumors, but again, you have to keep in mind that this is still exceedingly rare. Your risk of a brain tumor is very, very low. and meningiomas, of course, are very low. The typical onset, or when we see this, is usually in women who are 60 to 70 years old. So, of course, in pregnancy, the incidence is very low, that it's just not a very common tumor to have. We tend to see it more in the second and third trimester when we do see it. So why can these tumors grow in pregnancy? There is still a lot that is yet to be understood, and there's a lot of interest. There's a lot of neurosurgical data and literature talking about this, but the pathophysiologic mechanism is really not clear. There's two main hypotheses that people think about. It's the endocrine and the vascular hypotheses for why these tumors might grow. And we think it's probably a subset of these tumors, that not all of them will grow during pregnancy. So I pulled out kind of this diagram supporting why hormonal changes in pregnancy could affect the meningioma, and then also just highlighting that there's a lot of reasons or arguments against this hypothesis. So we think that in meningiomas, upwards of 70-90% of meningiomas will have progesterone receptors, and that could in the late part of second and third trimester, this increase in progesterone, could that trigger a cell-mediated growth? Against this is that when we think of progesterone receptor antagonists for treatment of meningiomas, they've uniformly failed, and so it's been unsuccessful in treatment. Also, in postmenopausal women, when the progesterone levels are fairly low, why is that where we see the highest incidence of meningioma? So again, there's reasons for it and reasons for against it, but this is what's proposed right now as to why we might see this growth. Again, this is a large study that came out in Nature in 2021 that just highlights that meningiomas, there's not an association of meningioma development during pregnancy. So the epidemiologic data doesn't support that they can start during pregnancy. Glioma, so this is my kind of bread and butter. This is what I typically see in clinic. So these are tumors that arise from the supportive cells of the brain, from astrocytes, oligodendrocytes, ependymocytes. They can be fast or slow growing. They usually stay within the brain or the spinal cord, and sometimes we can see spread through local tissue invasion or spinal fluid in 15% of the cases. In pregnancy, similar to meningiomas, there's no increased risk of glioma development during pregnancy. It does have a potential negative impact on the behavior in pregnancy, and so several observational studies have shown that the tumor volume can increase during pregnancy. This is for low and high-grade tumors, that this is associated with clinical worsening, including seizures, neurologic deterioration, and then often they have seen dedifferentiation and kind of transformation to a higher grade tumor that's been reported during pregnancy. I think it's still very important to note that despite all of these observations showing that the behavior of the tumor during pregnancy can change, that there has not been a difference in overall survival, that survival has not seemed to be affected in our low-grade glioma patients. So low-grade gliomas, because our treatments are improving, that women have had, likely have had these low-grade gliomas for several years and will likely have them for several more before having neurologic symptoms, we often think that urgent treatment of low-grade gliomas is very rarely needed, and that we can defer tissue diagnosis during pregnancy until after in women that are stable. The hemodynamic changes, so the hypervascularity and increased fluid that we see during second and third trimesters, we sometimes can see an increase in overall mass effect, and again, that may explain why we see this change in volume during pregnancy of the tumor size. But the mainstay of treatment for most of our low-grade gliomas during pregnancy is going to be really symptomatic management with corticosteroids if we need it, anti-seizure medications, and then very rarely surgical decompression, but in patients who are clinically deteriorating, that surgery is necessary despite pregnancy. This is pulled from one of the large observational studies that we have just showing glioma behavior in pregnancy. And while this is not the largest observational study we have, I like the picture, and I think it's helpful to see what happens during pregnancy. And so they're looking at A and C are patients who have gliomas that were diagnosed before pregnancy, with group A treatment naive and group C being patients who were treated with definitive therapy with radiation and chemotherapy. And what we saw in both of these groups is that During pregnancy, they had a fairly low rate of change on their MRI scan, but then during pregnancy, you see this jump in the rate of change during pregnancy, and then it decreased again after pregnancy. But what's important about both of these groups and what other observational studies have shown is that it has not decreased back to the pre-pregnancy level. In the middle picture in B, that these are two patients, one no treatment in circles and then one who had treatment with the asterisks, and that there was a fairly stable size of the tumor before pregnancy and then during pregnancy. In these two specific cases that they highlighted, there was an increase in size. I will point out that with any of these observational studies, these are a very small number of patients, and we are measuring the rate of change in millimeters. So there certainly can be bias with slice selection, or if I wiggle it a little bit, am I getting a couple millimeters more or less? So just take it with a grain of salt, but it's very interesting that many of these observational studies have corroborated each other and showing this rate of change during pregnancy. This is from another large observational study, one of the largest that we have. And I pulled this out to show you what happens during pregnancy. And it's very similar in patients who are diagnosed pre-pregnancy as well, that we see kind of seizures as the most common presenting symptom in this group, and that most patients can safely defer their diagnosis and treatment until after delivery in the population that's diagnosed during pregnancy. This is what happens to them after pregnancy. And so roughly 90% that were diagnosed during pregnancy received treatment postpartum. In this particular study, the 3 people who did not receive treatment, 2 of them actually received treatment during their pregnancy and 1 declined. So almost everybody went on to receive definitive therapy after their pregnancy. In this group, 50% of these tumors were high grade that were diagnosed during pregnancy. So we did see a fairly high number of recurrence and also of mortality, that ultimately 25% of these patients did die. And then the kind of mean follow-up was 34 months. So this is something that can have significant morbidity and mortality. High-grade gliomas. So often when we think about pregnancy and brain tumors, we're often discussing low-grade tumors, but we do see high-grade gliomas. And these are very aggressive tumors with overall poor prognosis. It's the most common primary malignant brain tumor, and glioblastoma is seen in 2/3 of all of our gliomas. So despite aggressive therapy, it's something that has very limited survival. The average survival is about 15 months for these patients, and for our grade 3 patients or anaplastic astrocytomas, the average survival is about 2 to 3 years. We know that young age is a favorable prognostic factor, so it might be a little bit conservative estimate for our pregnant patients and our younger patients, but in general, these are tumors that have very poor prognosis. So because we're having better prognosis in our lower grade tumors, we've had a greater number of patients that have really expressed interest in becoming pregnant, and primary brain tumors during pregnancy can have serious complications, and it's something that we really need to discuss with our patients. I think it's really important that a lot of these guidelines are really recommendations from observational studies, case series, case reports, and expert opinion. We have no randomized control trials discussing this or addressing this issue in this population. Before, probably about maybe 10 years ago, and even before then, the recommendation really had been that anybody with a brain tumor shouldn't get pregnant. And I think that obviously that's shifting, right? As our treatments are becoming better, people are performing better, and living longer. Young reproductive age women are asking, is it possible for me to become pregnant? And so I think we've shifted in how we counsel our patients too. And so we focus on this pre-pregnancy counseling. And I think that this might be one of the most important aspects to discussing care with our patients, because it can certainly make a huge impact in their reproductive decisions, but also in their decisions about how they want to be treated for their tumor. So counseling before patients become pregnant is incredibly important for informed decision making. We absolutely have to talk to them about the possibility of changes in tumor behavior, which we discussed, the benefits and the risks of some of the neuroimaging that Dr. Spiro had discussed, and our anti-seizure medications that Dr. Pinnell had discussed, that these are really important factors in our patients, and that the potential for need for oncologic therapy peripartum, during pregnancy or even after pregnancy, that could be possible. So pre-pregnancy counseling is really important. Timing of pregnancy, most patients will ask, well, when is it okay? If they've had chemo and radiation, when can I get pregnant? And there's actually no good data or no good guidelines for brain tumors specifically. In other cancer types, we often say about 6 months from last chemotherapy. Is IVF safe? The answer is we don't know yet. There's theoretical concern, but there's only been a couple case reports, so I think it's insufficient and not necessarily substantiated yet. Monitoring during pregnancy. So there's no guidelines about how frequently we should monitor. All the recommendations in our systematic review say we should monitor, but nobody says how to do it. I propose, pre-pregnancy scans that should be stable, following for low-grade tumors every 3 months during pregnancy, and then thinking about that 32 to 36 week mark, because at that time, if we needed to intervene with an intervention, it would be fairly safe for mom and for the fetus if we needed to induce pregnancy and do any kind of treatment modality, that would be an optimal time to intervene. Dr. Spiro talked about the gadolinium contrast and that it's a category C drug. It can cross the blood-placenta barrier, but we don't have any reported birth defects. So in patients with high-grade gliomas and glioblastoma, I think in that particular case, that would be an instance in which giving contrast would be necessary, as it might change our management, that we may, intervene earlier in those patients if we have a high suspicion for a high-grade glioma. The treatment is surgery initially, so surgical resection. For our low-grade gliomas and our meningiomas, oftentimes we can push this off and defer until after pregnancy. If our high-grade glioma patients, often they present with massive cerebral edema, focal neurologic deficits, and rapid clinical deterioration anyway. These patients we often will need to treat despite them being pregnant and despite kind of the timing of their pregnancy. Ideally, if we can defer until after the first trimester, that's great because of the fetal vulnerability. But kind of the care of mom, if she's clinically deteriorating, then we can perform any surgery during pregnancy regardless of the trimester. And we really need our neuroanesthesiologists and our neurosurgeons and our MFM group to help us with this. So surgery should never be excluded for these patients just because they're pregnant. The radiation and chemotherapy. So ideally, we would want to defer this till after pregnancy if possible. It may not be possible in all cases. So for our high-grade glioma patients, if we have to do radiation, we often try to minimize the scattering. So we do kind of axial of the head and do abdominal shielding to try to avoid as much radiation exposed to the fetus as possible. Try to avoid chemotherapy during the first trimester, especially alkylating chemotherapies like PCV or temozolomide. There's a case report of 6 babies that were born after being exposed to alkylating chemotherapy, and they didn't have any birth defects. But again, that's 6 patients or 6 babies. We don't really know. And obviously, we would try to defer if we can. One potential option for chemotherapy during pregnancy is an implantable chemotherapy called carmustine. And so that can be implanted at the time of surgery and actually has 100 times the concentration of carmustine we would give systemically without any kind of cross into the blood. So when they check levels in the blood, that it's very minimal. So we think it's probably safe in pregnancy. And then, of course, our symptomatic management. We've already discussed kind of seizures in pregnancy. It's the same with our pregnant glioma patients. However, one little thing I would say is that there's no evidence for primary prevention of seizures in gliomas. Perioperatively, yes, but not primary prevention. And then, of course, we use steroids for cerebral edema. And then for venous thromboembolism, our high-grade glioma patients, there's an increased risk for blood clotting. And same within pregnancy, there's a slight increased risk for blood clotting. So there's no specific guidelines, but it would be interesting to look and see if those high-grade glioma patients that are diagnosed during pregnancy, would they benefit from having prophylactic anticoagulation, and they might. For obstetrical treatment, so essentially we follow the obstetric guidelines and their criteria for stable patients. A lot of early data was showing maybe was C-section safer than vaginal delivery for our glioma patients, but there's not been any benefit of C-section over vaginal delivery in multiple observational studies. So in patients who are stable, who don't have significant cerebral edema, we think that this is safe, and so we counsel our patients that either is okay, and that it's a discussion that they should have with their OB-GYN, their neurosurgeon, and their neuro-oncologist. I'm not going to go through all of this because I think I am over time or almost over time for you, but this essentially goes through kind of the algorithm for what to do before pregnancy. And then the next slide will be during pregnancy. And this is what we've already discussed, that if you're stable, we can proceed as normal and follow with close monitoring, managing your symptoms with anti-seizure medications, corticosteroids, and then delivery with vaginal or C-section are acceptable. And then we treat you the same afterwards, that we follow it with definitive therapy. If you're unstable, of course, we need to intervene earlier, and if we need to think about surgery depending on where you are in your trimester. Or do we continue the pregnancy, or do we try to protect the fetus and mother as best we can and provide radiation and chemotherapy during pregnancy? And then, of course, during pregnancy, we think about, again, where you are in the pregnancy and if you're stable versus unstable, and that's going to dictate our management. So brain tumors in pregnancy require a lot of planning, pre-pregnancy counseling, careful monitoring, multidisciplinary care. It can provoke clinical deterioration and tumor growth. And again, I think there's no significant benefit of C-section over vaginal delivery. There's a lot of unanswered questions. When should we discourage pregnancy? There's a lot of ethics that, of course, we're not even bringing up today. That would be a whole different, probably, conference in itself. What is the best monitoring schedule? The one I propose is just what I tend to do, but there's no specific guidelines, and we need more guidelines for this population. Is IVF safe? And how and when can we give chemoradiation during pregnancy to keep it as safe as possible for mom and for fetus? So thank you. And then I'm going to put this up here since I'm over time, but I get asked about this a lot, so I'll just leave this up here for right now. All right, thank you.